Okay, so it's now 11 o'clock. I'd like to welcome you all to the HDR co-sponsored with NHS Transformation Directorate webinar around trusted research environments / secure data environments, which is a broader term which Nicola will explain. So a few house rules before we start. Anyone's free to use the material from this. Please be positive in any questions and respectful. And if you do have questions, please use the Q&A function to make that clear to us. And we will be having an initial talk from Nicola from the Transformation Directorate, followed by a panel discussion, and I'll introduce panel members when we get to that point. You'll be able to put questions. We'll start with some initial discussion in the panel, and then we'll use the questions that come up. So please put those in the Q&A, and you can vote on those as well, so we can see which ones are of interest to multiple people. So let's just move on to introduce what this is about. So there's been quite a lot of discussion around making data, particularly health service data, when it's sensitive, more secure, to enhance trust and to coordinate that in a better way as well. So Health Data Research UK set up the Alliance of Providers of Data in the UK, which now has more than, I think, 60 members, and has built things like the gateway to make it easier to discover those data sets. But how do you make those data sets accessible for researchers securely? And the mechanism has been, that's been talked about a lot and been implemented by various parties, is what's become referred to as trusted research environments, where the data doesn't leave the environment. You have to come and do your work inside that environment. Now, that's a wide group of individuals and organizations have started adopting that, started calling things trusted research environments, obeying what are called the 5 safes, which was first introduced by the Office of National Statistics. But if we're going to go broader than that and have adoption by the NHS as a whole, we need standards and we need a framework. And so that's what Nicola's going to talk about and introduce where we've got to. And this is very timely, of course, because last week, Ben Goldacre's review, which is much wider than just trusted research environments, was published. It's 200 pages long, so there's a lot in there, but it specifically also talks about trusted research environments. So that's what this is focused on, and I'll hand over now to Nikki to talk about the NHS strategy. Nikki.
That's great. Thank you very much, Tim. So hi everyone, I'm Dr. Nikki Brassington. I'm Deputy Director for Data and Analytics in the Transformation Unit. And as Tim has nicely lined me up to talk about, I'm going to be talking to you about all things secure data environments today. So if we can move on to the next slide, please. So before I dive straight into secure data environments, I just wanted to talk a little bit about where my team are positioned, and also talk about the stakeholder map as well. There's sort of, because this is such a large piece of work, lots of players involved. So as mentioned, my team sit in the NHS Transformation Directorate. Within that, we're actually part of a joint unit. So we sort of have management or line management into directly DHSC, so Secretary of State, and we also work with NHS leadership, so Amanda Pritchard, and Tim Ferris is our Transformation Director, so work directly to Tim as well. And what I should say is so that's kind of our leadership, but we've also got a lot of stakeholders, as I've mentioned. So stakeholders within DHSC, so that analysts working on health data there. We have NHS analysts that we work with, and we also have another range of stakeholders. So as you can see on this slide, a range of researchers. We're working very closely with HDR UK as Tim has introduced. We also are working with technical experts. We're working with regulators and advisors, so the National Data Guardian, for example, and then sort of a really important piece of this puzzle as well is that engagement with the patients and the public as well, to make sure what we're looking at and the framework we're creating is something that's workable across the system. Next slide, please. So why are we doing what we're doing? So there's lots of opportunities across the system at the moment. So the NHS data is a real treasure trove, and a lot of that potential has not been realised yet. And we've got lots and lots of opportunities when we're working with these sort of really significant multi-data sets to look at a range of things that can be improving actually how we run the NHS and how we improve quality, costs and safety, looking at actually as we treat people, what those side effects look like and what treatments look like, also via research, development of better and new therapies, and then also research into disease and their causes as well. So there's a lot that's still to be unlocked with the NHS data, so lots and lots of opportunities. However, the current landscape we're in at the moment means that it's quite difficult to unlock that potential. So particularly, we've got a very fragmented system. It's very hard to navigate. So we're sort of very reliant on sending data out to people, so sending data sets out, and we have data sharing agreements, but that's on a system of trust and compliance to ensure they're using the data correctly, and also relying on pseudo-anonymization as well. And we know sort of previous projects that we've looked at bringing the data into a single place, because we're not looking at it with always with that sort of extra layer of security around it, hasn't always worked, and as a consequence that has made us quite cautious and slow moving as well, and how we share data and where that goes out to. So there are a number of barriers that we need to overcome. Next slide, please. And so just sort of building upon that, sort of where we've got to recently. So actually during the pandemic, we found that data was really critical for developing quick responses and helping us in the pandemic. As a consequence of that and wider things, Ben Goldacre was commissioned to create a review back in February 2021. Running alongside that, what was formerly NHSX and now as part of the Transformation Directorate, created a draft data strategy, and that came out in the summer of 2021. And again, alongside that, we were looking at collecting the GP data for planning and research. That was a program that sort of was progressing quite well, but actually when it came to the crunch and bringing that out, there was some reticence again about how the data would be looked after and what the governance structures were around that. So that program has been paused. And one of the things we've committed to, again in July of last year, was 4 criteria for looking after that GP data for planning and research. And you can see the 4 criteria outlined, and one of those is a commitment to using trusted research environments, or secure data environments, as we're sort of using as a larger umbrella term. But that's kind of helped set our direction of travel. And one of the sort of significant papers that came out was Principles and Best Practices for Trusted Research Environments, which was authored by HDR UK, and we have a foreword in as well. So that's really set the beginning of the direction of travel. That brings us up to what we're doing at the moment. So next slide, please. So you may have heard a couple of sort of recent announcements. So the first one was made a few weeks ago now, was a £200 million investment to boost NHS healthcare data research. And that was to look at creating a number of different trusted research environments. So one at national level, and also looking at regional trusted research environments as well. So that's a piece of work that has recently kicked off. And as Tim mentioned at the beginning, the Goldacre review was published just last week. And that has a huge range of recommendations, but a large part of that, again, is talking about trusted research environments and the benefits that they bring. Next slide, please. So off the back of all of that, what is the vision that we have and where do we want to get to? So what the remit of my team are doing, and that policy work that we're setting, is we're envisioning a future where we have a data access ecosystem. And I think that key there is access. What we want to do is shift that paradigm. We're no longer going to be shipping data off to various places where we have that trust and we don't have such sort of close oversight on what's happening with the data, to actually having it centralized and people come into it. So this ecosystem is going to be made up of a limited number of secure data environments, as I say, the umbrella term that we're using for trusted research environments, and also how our NHS analysts will be accessing data as well. And what we will say is all organisations that provide access to NHS data will need to conform to using secure data environments, and also conform to those standards that we set for secure data environments, and attain accreditation as well. Next slide, please. So I've sort of spoken a little bit about why we want to do that move, but there are three distinct areas or sort of audiences that there are definite benefits for that we can provide. So the first is public confidence. As I've mentioned, moving away from that shipping of data out to having it in a secure place that people who have had accreditation come into, makes it a much safer way. And that also means that we can be much more transparent about who is coming into that environment and exactly what is being looked at whilst they're in there as well. So that really improves security and transparency for public confidence. From the point of view of NHS and DHSC, this means that actually we've got much better use of data to support our population health management, and also that work that's done within the department, so shaping policy work as well. And that means that because we've got access to larger data sets, we can also be more innovative and be more focused on monitoring and evaluations as well. And then finally, researchers. Again, the power of secure data environments is you will look at systems that will be joined up, so you can now look at having those larger data sets, and they're going to be securely linked, and then they can be shared coming out of the system in a non-identifiable way as well. Next slide, please. So I've kind of spoken a bit about what a secure data environment is versus trusted research environments. So essentially, when we're talking about a secure data environment, we're talking about a digital platform which allows you to access NHS data. The way you come into that environment is very controlled. You have to be somebody who meets specific requirements, which we'll be setting out in our accreditation framework. And we use that term secure data environment, as I've mentioned a couple of times. We have trusted research environments, which we access sort of externally by researchers and innovators. And then we also have the secure data environments for that internal view as well. So for NHS analysts coming in and our DHSC analysts. So that secure data environment is to cover all of that aspect, not just the research part. And as you can see, there's sort of four benefits that we particularly wanted to draw out of secure data environments. The first is security. I've sort of gone through that a few times now. Also increasing the value of the data in the environment. So single data sets by themselves can be fairly useful. If you join those up, you can have a much more powerful data set, and again, driving that innovation that we've spoken about. There's transparency, which we've also mentioned. And then finally, is that privacy point of view that I've mentioned as well. So they're kind of the four real big benefits you get from secure data environments. Next slide, please. So I won't talk too much to this slide, but one of the things I just wanted to mention is actually where we are at the moment. There's already quite a few trusted research environments that have already been stood up. And as you can see, we've got some national environments. We also have those regional environments already set up, and then we have cohorts as well, and that's things like Genomics England and Biobank as well. And the reason we just wanted to sort of touch upon this is to show what we don't have at the moment is a national framework for the standards we're expecting for trusted research environments. And as you can see from the slide, we've already got quite a complex landscape. So what we're looking to do is to bring a standardization for how those secure data environments as a whole work, and to talk about interoperability as well, which is going to be a really key feature when we have the ecosystem up and running. Next slide, please. So given that, and given what we're trying to achieve, I just wanted to outline the four key products that we're looking to deliver. The first one that you'll see from us is looking at policy principles. So these are going to be 10 very high-level guidelines that basically provide that higher framework for what the approach will be for secure data environments, and that will be published in the alongside or within the data strategy, so that should be coming out over the summer. We're also producing a technical capabilities specification, so this is really getting into the details of what the expectations are around a range of things, so particularly those cybersecurity features, the airlock features we've spoken about, and a number of other elements alongside that. And then the third product is looking at that accreditation framework. So where we want to move to as an end state is for all secure data environments that provide access to NHS data will need to have accreditation to be able to do that. And then within that as well, anybody who accesses the environment has to sort of have those checks and measures in place to be allowed into that secure data environment as well. So they're kind of like the three main products, but then alongside that, we're going to have a roadmap. So this actually is going to be a really key document, because what we'll be doing with the first three documents is kind of outlining the end state we want to get to. The roadmap is going to be really important to help people see how they can get to that end state and how they can achieve that accreditation. And so what we'll be doing is actually looking at all ranges of digital maturity to help say where you are already on the journey, and therefore how you can carry on down that road as well. So there are our four main documents. If you could move on to the next slide, please. And so yeah, so I've already sort of gone through the direction we've set, but one thing I did want to flag is actually this isn't a done deal. We've not made exactly the decisions of what we're doing, and we're running down that road. Everything I've spoken about we'll be publishing in draft, and the reason for that is we want to make sure this is a consultative process. So what we're really looking for as we go down this journey is input on how we achieve those tight controls to protect patient data, whilst at the same time making sure we're facilitating medical research and innovation within the NHS, and we're not putting barriers up that's stopping any of that. We want to consult on how secure data environments hosts will engage with patients and with the public, and sort of get involved in sort of that decision-making process and help influence that. We also, again, want to have a conversation about the extent to which we should be implementing open data practices. So again, sharing code, being very clear about what has been happening in those environments. And then finally, the one thing to acknowledge is there will be some justifiable exemptions where data needs can't be met by using the secure data environment. And again, what we want to make sure is, as we go through this process, we are having everybody's voice being involved, because what we don't want to do is come up with an end state product which shuts off that innovation. So that's something that we'll be looking at as well. So like I say, all of those things we want to come out and have those conversations alongside the main parts of what we're doing. Next slide, please. So this is my last slide. I was just going to quickly run through the timeline of where we're up to. So across the top is a timeline of those products I've spoken about, and at the bottom it's that public engagement. So from January around till now, we've been starting to develop both the principles, the tech spec, and the accreditation to sort of have some base to work off of. In sort of end of spring, beginning of summertime, we will be publishing those policy principles, which will go in the data strategy. As I've mentioned, they will be open for collaboration with people and comments coming back as well. So that's not exactly a done deal with those. In late summer, we will be publishing blogs on the technical specification, the accreditation framework, and letting you know where we've got to with that. And along that, there will be ongoing engagement. And then in autumn, we're looking to publish the finalized policy principles after we've had that consultation over the summer, and then the tech spec and the accreditation framework. And at that point, once we have sort of those more firmed up, we'll be looking at creating that releasing that draft of the implementation roadmap as well. So as I mentioned, just wanted to talk about a few areas of engagement that we're running on as well. So we've already begun engagement on those draft policy principles and the technical specification, and that's with NHS users, researchers, and the patient and public as well. As we move forward, May onwards, we're going to be testing those principles. So yeah, if that's something you're interested in being involved in, keep a lookout, because we will signposting when we have those opportunities. But yeah, so that is all I wanted to say. So yeah, thank you very much for listening.
Thanks very much, Nicola. So we're now going to move to a panel, and I'll just introduce the panel members. So there's Ben Goldacre, who is Bennett Professor for Evidence at this new institute, the Bennett Institute for Applied Data Science in Oxford. And of course, he's the lead for, well, he is the author of the Goldacre Review, much of which talks about TREs. Then there's Debbie Keatley, who is a member of the Public Advisory Board at Health Data Research UK, but also a Use My Data member. So she's the expert around public engagement, PPIE, on the panel. Then there's Bradley Quinn, who's Associate Director of Insight at Health Innovation Manchester, one of the fundees of these regional TREs that's been mentioned. And finally, Shashil, who's Chief Technology Officer at HDR UK and is has a wider involvement in TREs with the DARE program, which involves UKRI. So of course, this seminar here is focused around NHS data, but there's other organizations talking about TREs beyond just the NHS. And I suppose I should say who I am. I'm Tim Hubbard. I'm Head of Molecular Medicine and Genetics at King's and seconded to Genomics England part-time, where of course we built a trusted research environment with big data early on, and also to Health Data Research UK, where I lead on the TRE workstream. So I'm going to ask a few questions to each of the panelists, and then we'll go to the Q&A, and there's already quite a lot of questions, so we're going to have a busy time. So firstly, Ben, you've got your documents. One of the things, and you've got Open Safely, of course, which is a TRE, but as discussed in your review, the model is with Open Safely, you don't let people to actually see the data. The model is that they can only submit code and get back results. So given the noisiness, is this going to be a barrier? I mean, it's already a sort of barrier operating inside of TRE. What do you think the issues are around that kind of model which you're pushing?
Well, firstly, as we say in the review, there are lots of different types of TRE, and fundamentally two, I think. One is a remote desktop environment where you get to log into a setting where you can see and interact with pseudonymized data very freely. And then secondly, there are more secure and more consistent approaches like you see with OpenSafely, which, as you say, is a project that I run. It's a complete open source framework for running a TRE in a very standardized and very consistent and efficient way where everything is done in a standard way. NHS data is noisy, complex, and hard to work with, as we discuss in the data curation chapter of the review. And analysts everywhere address that challenge of noisy data by doing plausibility checks, writing code to look for outliers, inconsistencies, and so on. At the moment, that's done in a hodgepodge of different environments in different ways, usually in direct interaction with the data, and as a consequence of that, without much sharing of code or methods for the curation. When you use OpenSafely, you do your plausibility checks, writing code to look for outliers, inconsistencies, and so on, exactly the same as you do in any other environment. It's really no different at all, but with the huge advantage that your data plausibility checks are done in a consistent environment with a consistent code base and shared with other users. Now, that's not a disadvantage, that's an advantage. It's one reason why OpenSafely has been so productive with a much smaller team than other TREs, because everything is done in the open, using consistent open code without duplication. That's one of the reasons why OpenSafely shipped 24 papers, 26 preprints with 30 projects approved from 18 external organizations. And that's not just relevant to OpenSafely. I think it's a real risk when people talk about TREs in terms of only the security benefits, because there are also enormous efficiency benefits from TREs. At the moment, the same data is stored in multiple locations, all slightly different, with duplication of effort on governance and implementation, but also the data curation and analysis work. So TREs can reduce all of the duplication around there, but also when lots of users do their data curation, data checking, data analysis, and data visualization in the same environments, using similar methods and functions and sharing their methods and code, then that huge duplication of effort is eradicated and can help drive up quality.
Great, thanks. Okay, so now turn to Debbie. So there's the technical frameworks, etc., but there's also, a lot of the driver here is engagement with the public. So, as Nicola outlined, this direction has partly come through the experience with GPDPR. What do you think's there's quite a lot of talk about transparency in some of Nicola's slides, but what about engagement? What do you think's going to be needed in terms of engagement?
I think Tim really would say engagement's not enough. It doesn't seem to me to be enough to touch and join and discuss with the public and then walk away and do your things. This needs to be built up and recognize that the public and patients are core key stakeholders in this, and that working with them is an investment in the likelihood of success or not. I think as Ben, having looked at the work that Ben's done, he's identified those similarities between care.data and GPDPR and those instances where trust is lost, resulting in loss of time, loss of access. That's frustrating for patients and people like me who are working particularly with cancer, but we can understand why people don't feel confident if they don't know enough. Then that's a rational response. And for example, I was thinking with the GPDPR, people experience government in different ways. So for example, a patient who's also claiming benefits might feel quite reticent about sharing their health data, with good reason. And we need to understand that. We need to meet people where they are. The work is not, it's not enough to just do engagement to explain what you're doing. You need to involve people in the oversight, in the governance of these bodies. And I think that needs to be in setting the standards, in accreditation, and actually making sure that the bodies who are charged with monitoring those are adequately resourced to do it. And that's a common problem, that we don't see enough resourcing being put into making sure that people do what they say they're going to do.
Okay, well, maybe we'll pick that up a bit later as well. There's some questions related to that too. Bradley, another strand of this is this national versus regional. You've got the national open safely linked in Nicola's slides, and you've got these regional. So what's, how are they going to complement each other? And, Ben's talked about duplication of data, for example. So that's an issue as well.
Yeah, absolutely. Thank you, Tim. I think it's fair to say that Greater Manchester has always had a bit of a reputation of doing our own thing, be that through devolution or a certain local mayor that you might know about. But for us, definitely Greater Manchester, we don't see the two things as opposed by any means. National TREs obviously have the benefit, as Nicola has outlined, of the value of a much broader scope in terms of coverage of data. But when it comes to local or regional TREs, it's oftentimes the proximity to the intervention that's being delivered, particularly for prospective studies or for monitoring or evaluation, that's really valuable, and that closeness to decision making and policy makers as well, alongside the nimbleness and agility that operating at a slightly smaller scale affords you in terms of governance, in terms of IG, providing that visibility to patients and the pace of change that we have at local and regional level as well. So because of that closeness, we often find it easier, I'd say, to articulate the benefit back to data controllers, who can sometimes perceive the value of sharing data for research as somewhat nebulous and removed from their work. If you think about GPs in particular, they don't see that value all the time being realised directly back to them when you're operating at such a large scale as a national TRE. There's also oftentimes with local TREs the opportunity to augment them with additional data sets that might not be appropriate for national platforms. That could be bespoke study-specific data sets, information captured by third-party technology like remote monitoring tools or patient-reported outcomes, for example, but do that securely by bringing information into the environment. And so for us in Greater Manchester, the real power comes from that combination of both. It's about being able to maintain the local agility, but also ensuring that we've got the right design principles and we're utilising the right technology to ensure that local and regional TREs can be connected up and federated to share resources and learning in line with the accreditation principles that Nicola outlined earlier. And the last thing we want to do is create a parallel track locally, because that isn't beneficial for anybody.
Okay, and finally, Shashil. So this question about multiple TREs, Nicola's talked about, linking them together, but that's going to require technology, infrastructure. There's been you're involved in a lot of work around standards and developments. There's value in doing, even if we have a limited number of TREs in the UK, going outside, there's the European Health Data Space, potential links for example, to Japan. How are we going to do this? And is this actually going to work, given that GA4GH, this is Global Alliance for Genomes and Health, it's existed for many, many years now, and it's meeting again today and tomorrow. Is this actually going to get adopted? Is harmonization just too hard to make these things together?
No, I think that's a great question. And so one of the things that sort of, to answer that question directly, is the reason I'm speaking to you today through Zoom is because of standards. It's because people have worked hard for tooth and nail to try and set up all the internet standards that we're using today. And that is the baseline on top of which innovative applications like Zoom and Skype and everything else builds on. I think we need to distinguish the difference between standardization and harmonization. Standardization is much more about providing uniform business processes, methodology, technology, so you can have a deterministic outcome whenever you do something. When you log into a site, you are presented with a username and a password and you're able to access it. Harmonization is much more about eliminating or preventing variability between the different standards. And that's important to note because we need to standardize on the boring stuff, the things that nobody cares about, so other people can build innovative things around. So within a TRE, very simple standard around, can I find what data sets are available in a TRE? Very simple standard. That's all you need. That gives you transparency. That gives you predictability to be able to say, I need to go to this TRE to access data. Another standard could be standardizing the process by which you request access to data. There's only a fair number of questions that you need to know. You need to ask who you are, what project you're doing, what's the purpose of the study, what outputs are you generating, where you're running the analysis, and what kind of analysis. 5 basic, 5 safe questions. Can we standardize on that? So try and pick the right set of standards that we can all agree on so that we can then harmonize the variability between the different TREs. It is definitely possible. The internet is a good showcase of this. Now, healthcare standards traditionally and retrospectively has been a hodgepodge of standards. You've got HL7, OMOP, ICD-10 has been updated, and there's a few questions in the chat about that as well. But one of the things and one of the approaches we need to take is a 4 nations approach of trying to pull together the expertise of bringing everybody who has a deep understanding of data, deep understanding of technology, bringing software engineers, as Ben has highlighted in his reports as well, bringing governance professionals to work and interoperate together. So standardization is also about interoperability between people. And that's important here. And we need to continue that conversation because everybody's expertise is important to bring together an idea. And public and patient is at the center and at the heart of it to be able to ramp up all of our work that we need to do.
Okay, so obviously interoperability becomes harder the more you have. So I mean, there's lots of Q&A questions here, and I'm going to ask one which kind of immediately relates to that, which is how many TREs should there be? Which maybe I'll ask Ben about, because you've said that, you've made a statement about that. The NHS is also saying a limited number, but Nicola had that slide with this huge ecosystem as well. So how many is the right number?
Look, I think the objective is to eradicate needless duplication of effort, but also to eradicate some of the data access monopolies that have grown up around key data sets. In the review, essentially, we say very slightly more than 1 TRE for national data. Now, that's simply because I think in order to get one good performance TRE that works nationally for NHS data, you may need to build slightly more than 1 because you want to overcome the challenges of inertia, monopoly that come from lack of competition. However, I think anybody proposing to build a new TRE with national NHS data should be required to show that they are addressing user needs that cannot be addressed in any of the current TREs. And secondly, that they have made good efforts to address those user needs in one of the current TREs, and that has proved to be impossible. For local data, the picture is slightly different. I think it is very reasonable, as we say again in the review, to have different TREs for local NHS data sets, and that's in particular in recognition of the fact that covering local patches, for example, with ICSs or groups of ICSs, you'll often have your own local copy of national data sets like GP data or HES, SUS, and so on. But you'll also have a patchwork of local data like occupancy data of care homes and invoicing data. That's often very, very different in a patchwork across the country. And it's reasonable for people to do local work on that. However, there will always be commonalities between those local TREs. So the other thing that we recommend is developing a standard TRE framework that can be implemented in each of those local area TREs. Now, there are basically 2 ways of doing that. One is you can define some standards and let lots of people try and run at it. That's substantially more expensive, substantially slower, substantially more likely to lead to delays and non-delivery. The second is that you can start to assert what those local platforms should look like and provide people with simple off-the-shelf options that they can take. I think the second, for obvious reasons, is more desirable, but it's not going to be as simple as procuring one commercial off-the-shelf option. I think what you need to do is have a mixture of standards, working practices, and then underlying computation infrastructure, but that gets boring as hell. I'm available to discuss that at length for anyone who's very interested. I think the real challenge actually with TREs is not running before we can walk. 90% of the work that's done with NHS data can be addressed very quickly with some good, simple standard approaches to TREs and indeed to federation. We've got federation up and working in Open Safely. There have been previous bits of work on federation with projects like data shields that address some but not all needs. I think we can do 90% of the work on TREs with things that we already have. And I think it would be a mistake to try and set out the perfect framework and principles and roadmap of everything that you might do for every possible user need, for every possible user in every possible future at the beginning of developing this program of work. I think that would be waterfall procurement by stealth. And actually what we need to do is agile work. We need to do what we can do right now, learn from that. And I say that in particular because there's been a massive strategic shortcoming in this country. We don't have a large group of people who have software engineering skills combined with health data research skills. We don't have a large group of people who have built TREs in the open, sharing their methods, sharing their code. We don't have the people and the capability to do this job well today. So we need to practice by addressing 90% of user needs in a stripped down set of TREs, and then learn from that as we go. And that's when we can start to address the more complex needs.
Okay, thanks. And I certainly agree with you about having more than one, because my experience of the genome browser era was having two was fantastic, because we would look over each other's shoulder and, you know, they were doing it faster than us. It put great pressure on us to speed up and things like that. So I'd agree with that. There's this one, I'm going through this massive of questions. I'm trying to do some of them from who's upvoted them. So one common question, I think, which I'll ask to Nicola, what type of organization is going to be able to hold data in a TRE? And how is linkage going to be handled? I think obviously you can, if you're a researcher and you've got research data, it's, you know, that's a separate thing. But from an NHS point of view, what's the answer to this question?
Yeah, so what I've said with the accreditation framework is there's kind of two elements to that. So the first one is for the secure data environments themselves. So if you're somebody who wants to host a secure data environment, you will need to have that accreditation. But then under that, there will be a framework which you will then be administrating, which will be about who comes in. So this will very much be about what people are coming in and what their purpose is for. So what we will be putting in that framework is it's people who have got legitimate uses to do research. And that will also be industry coming in, but obviously that has to have, we're still using the same legal framework, we're not changing that, so it still has to have clear health benefits. And then what we would say is, so I think there's been a few Q&As about this, but the data we would be saying is you're not locked into the data that's only within that environment or accessible via that environment. I should say you can also look to bring in your data. We are currently defining what that means to bring in your own data and what requirements are around that. But if you're accredited and you've got a clear purpose for coming in, and then once the checks and measures have been done on the data you bring in as well, that can come and be accessed within that secure data environment. Okay,
one for Nicola. it says there's rightly a focus on public confidence being required for TRE to be a viable solution. What are the concrete steps that are actually being taken to involve public in shaping this? I mean, I think you mentioned one, or Nicola mentioned One London, I know that, but you're involved in, of course, my data as well.
Yeah, so one of the things, as I mentioned a couple of times when I was talking, is the data strategy will be coming out fairly shortly. Alongside that, one of the commitments that will be in the data strategy will be around that public engagement piece. So actually, the work we'll be doing on secure data environments is kind of an element that will slot into the data strategy, and we're looking at a range of things. So there will kind of be events that I would say were more on the spectrum of broadcast mode, if you like, where we'll be updating and giving information, but then there'll also be very much on the other end of having that ongoing engagement. As sort of Debbie rightly highlighted earlier, what we don't want to do is have a period of consultation and then we're done and dusted and off we go with everything we've learned there. One of the things, sort of one of the concrete steps we're looking at is actually, as part of the accreditation of a secure data environment, there will be a requirement for that patient and public engagement to be built into what you're doing on your secure data environment. So that's an ongoing process. As the kind of the earlier, so the sort of defined piece of work I was talking about, we're looking at setting up patient panels and things like that, so we can have that wide engagement as well. So, but like I say, that's linked to what's happening with the data strategy. So we'll be folding through what they're doing with their very large piece of engagement there. Debbie,
do you have comments on this?
Yeah, I do. I think it's really critical, and I think part of it is a cultural shift, that patients and public aren't seen as an amorphous blob that you have to talk to them and get their tick box okay, and then you carry on. We are partners in this, and we should be talking together all the time. And when patients and public say, no, actually, I'm not comfortable with that, it's not helpful to find another way to frame the question and carry on and do it anyway. You need to listen and change. And if you don't do that, you don't build trust, you don't build confidence, so you end up with really, really incomplete data. So there has to be some way of stepping back and making sure that everything, I recognize that it's slow, democracy is slow, it's tortuous, but it works quite well on the whole when it's allowed to. But you do need to respond to criticisms, to challenges, and actually address them. And I think that's one of the things that's been frustrating for people to learn, because there has been really good pieces of work like One London, but that's a piece of work. It has to keep going everywhere.
Okay, thank you. So another question is, which I think I'll address to Bradley, what's the vision of bringing 200 trust data together into a small number of secure environments? I guess at the regional level, that is an issue. I know from my own area in Southeast London, you've got all kinds of data sets inside hospitals, and that's more than HES data. What are you doing? How do you see that working in the Manchester setting?
Yeah, thank you, Tim. I think it's a great question, and I think it's a live issue that we continue to deal with at the moment in Greater Manchester. I think there's probably two things that I'd mention there. I think the first one is an important distinction between the sharing of data for clinical purposes and then the sharing of data for analytics and research purposes. So you've referenced HES data, for example. Think about our experience locally in terms of coordinating data into a shared care record for usage for clinical purposes. Much of that data in terms of the format around HR7 messaging, ADT, communications, etc., just isn't appropriate for the purpose of undertaking analytics and making it available for research. It just doesn't bring the value that we need from that kind of information. So I think an important step for us in terms of dialogue was both, yes, sharing the data for clinical and operational purposes, but then also recognizing that the same data may not always be appropriate for research and analytics uses as well. I think the other part of that comes down to collaboration, and it's an area that we always touch on in Greater Manchester. As I mentioned before, devolution, it's a big part of our work, is that real close collaboration between organisations. And we've done lots of work to really cement this approach in terms of a Greater Manchester trusted research environment. So move away from individual hospital level TREs for MFT, for example, who are investing significantly in a new EPR rollout, moving away from the Christie having their own trusted research environment, to thinking about opportunities to deliver efficiencies in terms of overhead, in terms of the boring stuff that Ben mentioned before about data management processes, in terms of onboarding of data sets. Do that once in terms of infrastructure, but do that in such a way that enables organizations to focus on the interesting side of the research and really get the value from that innovation too. So they're the two elements. I think it would be the distinction around clinical data versus data for research and operational purposes, and also the opportunity to do things once at scale and then realize the opportunity cost in terms of focusing on the value added.
And just to add on that, I think that's great 2 points. And just to add on that, we need to have a very holistic view of health. So air pollution data, environmental data, this is all determinants of health. So bringing the work we need to do is not just purely looking at health data or NHS data, trying to bring together a holistic view of your person's health. And also, one of the things we need to highlight here is science is global. Our ambition should be to leverage the expertise internationally and collaborate internationally to be able to facilitate the research and unlock the gains that we can make from our use of this data, whilst maintaining all the privacy and security around that data. So that's where standards and interoperability and federation comes into play, and that's what enables international research.
Right. So that's a lot of this has been from a clinical point of view or the patient point of view. What about the researcher point of view? This is a top question. How do we keep up with providing researchers and innovators with appropriate, I guess, platforms, computing power, support, given that this is now going to be the preferred route? I think, Ben, how about you ask this?
Sorry, I'm not sure I followed the question. Can you ask it again?
Well, it's about, how do we support researchers, I think. And I imagine you would say learn open safely.
No, not at all. So I think, first of all, as we say in the review, if we want to get more people doing more good work with health data, then we need to get more crossover between the software engineering community and the traditional health data researcher community. At the moment, there's not sufficient recognition of the reality of how data analysis is done. Data analysis is done by writing code. And if you don't have people who are professionals at writing software in order to do good work with that data, then you won't get good outputs from that raw data. So I think the key strategic need right now is to get funders in particular to recognize the need for capacity building, fellowships for research software engineers, funding for projects that is open and competitive rather than given by political preference, as happens too often at the moment, to projects which are built around code for making better use of health data and for teams that are building capacity in that regard. So I think that's the first challenge, bringing software and software developers and data analysts together. I think the second challenge to meet researchers' needs is providing them with data analysis environments that support efficient working. So when you log into a remote desktop environment, it's very easy to fall back into the traditional ways of working, where you do a little bit of data curation in SQL, then a little bit in Python, then a little bit in Stata, and there's no documentation. And every time that anybody wants to do any good work with the data, they're starting from scratch. And when they get to the end of their project, they throw away all that good work. There is a better way of working by sharing your code, by using consistent methods. And what's interesting to me is that those better ways of working are increasingly adopted outside of the health data research ecosystem. So reproducible analytical pipelines is a set of best practices around modern, open, collaborative working with data, developed by Government Digital Service and Office of National Statistics. It's being very widely adopted across the Government Economic Service, Government Statistical Service, the analytic function in government. It's not yet the norm, but it's growing extremely quickly. It's got training associated with it. It's got best practice templates associated with it. And it's all built around this approach of share your code, write documentation, avoid duplication. And I think if we can get funders to recognize that you need to support that kind of approach in the research community, then we'll get a real explosion. Because what we want to get to ultimately is a situation where a new analyst in the NHS, or a new academic researcher, or a new innovator from the life sciences community comes to the data and finds accessible data that's also nicely curated, plausibility checked. The noisiness of the data has already been interrogated and addressed by other people, and then they can just jump in and start doing their analysis.
Thanks. One of the things that is, is a question of funding and stability. You've mentioned capacity building, but there's a kind of broader thing which has come up in a couple of the questions, pointing out that TRE or some of the concept was supported before HDR even, and not all these things have persisted. So maybe to Nicola, where's the confidence that these things like regional TREs are going to survive beyond, there's this 200 million, it doesn't sound like it's going to be enough. Is this going to persist as a structure?
Yeah, no, that's a really great question. And that's something obviously we've been thinking about a lot. And I think that the key is going to be to make sure we do get that point around federation that we've spoken about earlier and standardization. Because what we want to make sure is we set things up and they are running. So they're places that people want to come to make use of. And I think that's going to be the key is, we have to make sure that they're working and they're making it, it's a new way of working that people have to get used to. Once they've got used to it, it provides a very clear and easy way to come in and sort of do your research. So I think that is going to be the key, is making sure, as everybody has been saying, the devil is in the detail for these things. We need to make sure they're working. And once we make sure that they're fit for purpose and they're really benefiting people, I think that is how we can be more certain of that sustainability. But I think that's really going to be the key, getting it right and getting it to be a place that people want to come and do their research.
Thanks. So we are almost at the hour. So I'm going to just go through the panelists and you have 30 seconds to say your closing remarks. So I'm going to time you. So start with Ben.
It's great to see forward plot movement on this, but it's only going to bear fruit if we start building a community of open collaborative working around better use of data in TREs, and that will need open competitive funding from funders like UKRI and NIHR to people who are producing good work in this space.
Great, 25 seconds, excellent. Right, Debbie.
I think what I want most of all really is that people can see the working and that there is public benefit, clear public benefit, and that's prioritized above commercial quick returns. So I think that is important to build something that will endure.
Great, 26 seconds. Bradley.
Well, I've got a record to break, Tim, by the time. I'll keep it nice and brief. I think the main thing for me, and I think it's been a recurring theme actually in today's session, is really that emphasis on sharing, on reproduction, on setting standards, but also really important to think of investing in not just infrastructure and technology, but also the workforce and the skills that are needed both within the NHS and the wider health research ecosystem to really make this stuff and get value out of TREs.
Great, 25 seconds. Shashil.
Thanks. I don't know what else to add. I'll focus on the boring stuff. So one analogy I would just add in terms of standardization is there's loads of standards on paper sizes, for example, let's say A4, A5, but nobody standardizes on the paper weights or thickness. So the standardization of paper allows printers to work. You don't need to standardize everything. So pick the right things to standardize and let the others go. That allows you to interoperate with various different systems.
26 seconds, thanks. And finally, Nicola.
Thanks, Tim. So the main thing I wanted to say is we do want to make sure this is a collaborative piece of work. It's really exciting what we're doing, and it's going to be a real paradigm shift. So we'll be sending out, I think there's information coming out that we will send an email address, so do get in contact if you're interested, and also keep your eye open for the data strategy, which will be coming out later on in the year. Excellent, 25 seconds. So, right, we are at the hour. Thank you very much, everybody. Sorry we didn't get to your questions. I think we will go through the Q&A and try and respond maybe in the chat, or somehow anyway. We won't lose those, but I'm sorry we didn't get to them all. There were just too many. So thank you very much for attending, and there's a recording of this, so you'll be able to go back and look at it. And there's a slide up now with some links to things that are relevant to this. So thanks very much, everyone. Bye.